it's Dr. Purcell, and as promised, we're just going to do a quick overview of intracranial regulation as the concept because we're covering the drugs that are dedicated to intracranial regulation from pharmacology perspective, and those are the ones we're using to treat things like epilepsy and seizures. We're going to come down here and look at how Giddens defines the concept of intracranial regulation. The intracranial means that any of the components, here I'll highlight it, that lie within the skull. Oh, whoops, so sorry. I got a little crazy there. No. Any of the components that are within the the skull, I'm sorry. And that includes your brain, your circulatory system, and dura mater. Here, I'll see if I can get this to, there we go. Regulation refers to compliance and maintenance of balance. And you can well imagine within the brain, we like a lot of regulation. We want balance to be maintained. And so when we say intracranial regulation, we are talking about maintaining a balance that promotes an environment that's conducive to optimal brain functioning. When there's a brain tumor, when there's a lack of perfusion, when there's a problem with neuronal synapsing, we don't have optimal brain functioning. And so the concept of intracranial regulation includes anything that can affect the contents of the cranium, what is actually inside the skull. So although, there's a peripheral nervous system and a spinal cord and all these things that feed the brain and affect perhaps the regulation of the balance in the brain, the concept from Dr. Giddens, and when we say intracranial regulation, that concept is limited. It's defined as the mechanisms or conditions that impact intracranial processing and function, specifically the conditions that affect the contents within the cranium. So it's not going to be about things that are not within the actual skull area. You'll see as we go down here what I'm talking about. The scope of this concept goes everywhere from optimal functioning to impaired functioning. And it's within the impaired functioning that we see even more of a scope. There can be very mild functioning from perhaps a concussion causing mild impairment, moderate impairment from perhaps a blow to the head that caused a subdural hematoma that resolved, or even maybe early onset Alzheimer's or dementia, to severe impairment that may come from a traumatic brain injury, a brain tumor that's growing, and increased intracranial pressure. So the normal processes that should happen within the brain is going to be divided into all these different sections of the brain. And we're not going to go into all of that today. What I want to focus on is that one of those sections that is responsible and can be affected, that affects the normal processing, are the neurons. And the neurons direct signals from cell to cell through the dendrites and axons. So you probably remember what they look like little starfish or something kind of. The dendrites and the axons that are within the brain that the nerve impulse goes across. So it can go from one cell to the next cell. And nowhere else in the body do we have something quite like what we have in the brain where that occurs. And to get optimal intracranial regulation or balance, you have to have that transmission of impulses to be balanced and to be controlled. And those impulses cannot become crazy and overactive, or you will start to see changes in the functioning of the brain and then manifest as behavior or other clinical signs. I'm scrolling down now. We're on page 115 in Giddens, past the structures of the brain and the general functioning to talk about, what does brain function depend on? And I'm going to just touch on this because I want you to just realize how almost every concept is going to be involved with optimal brain functioning. But the big ones are right here. So the brain can't function unless it has a consistent supply of blood that's bringing oxygen and nutrients. So if you cut off that supply, the brain can't function and the brain will die. So in order to have a consistent supply of blood, you need to have good perfusion. So now if you have adequate perfusion, you know the brain's going to get adequate blood. But if you have inadequate perfusion, and perfusion that's been altered by plaque in the or arterial and atherosclerotic disease, then you know the brain is also affected because it's not getting the consistent perfusion of blood that it needs. Well, along with the blood should come oxygen, hemoglobin and oxygen. And so that's dependent on gas exchange. If somebody is not having adequate gas exchange, then the brain's not getting adequate oxygen. And so you will start to see problems there. And then the carbohydrates are involved with glucose regulation. And that is the only source, really, the main source of fuel for the brain. And when glucose is gone or absent or not provided to the brain in adequate amounts, then the brain cannot function. Likewise, if the brain is exposed to too much glucose, we start to get damage that we see also throughout the body from increased levels of glucose. So you can imagine now, start putting some pictures in your head of the kind of patient that might actually have a problem with intracranial regulation because they have issues with perfusion, gas exchange, and glucose regulation. So I wanted to talk a little bit about that, but now we're going to go back to the seizures and epilepsy and the focus today of what we're doing. Here we go. There's all these areas of the brain and things that can happen. So the things that can cause variations and context within intracranial regulation are discussed here. Impaired perfusion is the first one because honestly, if perfusion's impaired, that's going to be the big thing that could possibly kill your patient. But the second thing is about compromised neurotransmission. And in order for the brain to have balance and function, normal function, it needs to have the transmission of neurotransmitters. They need to be going. The transmission needs to be happening from cell to cell. In order for me to be sitting here and speaking and moving a mouse and using my eyes and looking and thinking and processing, I have to have a lot of transmission going on in my brain. A lot of neuronal activity is happening. And if you interrupt any of those, you're going to see something happen. So if we interrupted certain ones, I wouldn't be able to speak or see. Others might interrupt my ability to move the mouse, motor abilities. So whenever we compromise functioning inside the brain, what the nurse is going to see is clinical manifestations of altered functioning. And you learned your cranial nerves and what functioning they're associated with. So that kind of comes back here as well from health assessment. So at the end of it's the last sentence under compromised neurotransmission. Seizures are aberrant neuronal activity that can manifest clinically as disrupted motor control, sensory perception, behavior, and or autonomic function. Let's break that down. Seizures are, here's the definition of what a seizure is. It is aberrant neuronal activity. So when we have those neurons and the transmissions going across, some of the neurotransmitters are causing excitement. They're excitatory on the cells. Others are inhibitory. There's your balance. We have to have a balance between excitatory and inhibitory. Well, you start to mess up with that. you have aberrant, crazy, uncontrolled neuronal activity that is now unbalanced, you're going to see a manifestation in the patient. That's the second part of the sentence. So it's aberrant neuronal activity that can manifest, that can be seen by a clinician, by the nurse as, so this is what your patient will look like if they have aberrant neuronal activity. They will have disrupted motor control, disrupted sensory perception, disrupted behavior, and or disruptive autonomic function. So any or all of those things can happen depending on how disrupted the neuronal activity is during a seizure. As we come down, we see this box 13.1. Oh, I'm sorry, that's not the box I wanted. That's causes of cerebral edema. We aren't looking at that. I wanted to come down here a little bit further. Hang with me. We'll get there. We're on a little trip here. There we go. To the section on page 120 of collaborative interventions, but we're looking here pharmacotherapy. So because impairments in intracranial regulation can come from a lot of different situations, brain tumors, head injuries, Alzheimer's, dementia, seizures. There's a whole lot of pharmacologic agents that are used in this area. For us, we are going to focus on the purposes of controlling seizures with anti-epileptic drugs. And they have the phenytoin here, Dilantin, and valproic acid, Depakote, listed here. So we're going to come down to where they talk about our anti-epileptics. Anti-epileptics can be used either to prevent seizures or to treat seizures. Sometimes if someone has a head injury or after cranial surgery, they have increased intracranial pressure, and we know that that is going to be a potential trigger for seizures. So we will actually start them on Dilantin, not because they've had seizures, but because we want to prevent the seizures until that we get that issue under control, and then we can stop that seizure medication. Or they might have a seizure, and so we give them the anti-seizure medication. The other time we use it for prevention is in people who have epilepsy, and we know that they are going to continue to have seizures. So what the medications do, we don't know how they work exactly, the exact cellular level mechanism, but we do know they act by stabilizing those nerve cell membranes so the transmissions can come across, but the membrane is going to be more stable. It's not as susceptible to those aberrant transmissions. It stabilizes those membranes and prevents distribution of the epileptic discharge. It's like the ground on a plug. If you don't have a ground and there's a discharge, an electrical current that happens and it's not supposed to, it can shock someone or cause a fire. But if you have a ground, it should go to the ground and not cause disruption by a fire or shocking someone. Kind of an analogy there of how the anti-epileptic medications work. It's the management of traumatic brain injury patients, as I mentioned, is we will start them on phenytoin initially because we expect that they could have seizures and we don't want them to. And that was what I just described as one of the preventive measures. Something that is said here and should probably be highlighted in red or bold, is that patient education is going to be vitally important, especially for patients who will be taking these medications regularly and continuously. We've got to address the serious side effects that can be associated with these medications and make sure the patient is aware of what needs to be reported and the importance of being adherent to their regimen. The Food and Drug Administration, about 10 years ago, issued a warning It's in the form of a black box warning on 11 anti-epileptic medications about the risk of suicidal thoughts and behaviors that are associated with those drugs. And so that's where we really need to do patient teaching and always ask at each encounter with patients who are on any of these 11 medications whether or not they're having suicidal thoughts. And that you'll learn a lot about that type of questioning when you have your psych mental health nursing course. I'm going to scroll back down here because it goes through a lot of other issues that are not part of our discussion. Here's our clinical exemplars for intracranial regulation, and they are divided by perfusion, transmission, and pathology. And so under perfusion, it's not surprising you see stroke and head injury. Neurologic transmission is limited to the epilepsy and seizure. And then the pathology are the patients that might have a brain tumor, Alzheimer's, an inflammatory condition, maybe encephalitis or meningitis. So here's our exemplar for epilepsy. And it's just a snapshot overview, enough to help you understand when I talk to you about the drugs, the purpose of using them. So epilepsy itself is a disorder. It's a disease, so to speak. And it is characterized by two things: recurrent and unprovoked seizures. Things like strobe lights have been known to provoke seizures in people, but these people don't have seizures at other times because of having epilepsy. It was provoked. You can provoke seizures with increased intracranial pressure, things like that, but it's not something that is a recurrent problem. So epilepsy is a disorder in which somebody cannot stop the process of these recurrent unprovoked seizures. And they have them because of the inappropriate or aberrant and excessive nerve impulses that are happening at the neuronal level in the brain. And what we end up seeing clinically when there's seizures are uncontrolled, and quite frankly, they can look very violent muscle spasms. And almost always there's loss of consciousness. And then if the autonomic system is involved, the person may lose control of bowel or bladder function. So, how many people are affected by epilepsy? How much do you need to know these drugs? About 2 million people in the United States have epilepsy. And about 1/3 of those people continue to have seizures even though they're taking treatment, which tells you that, we're doing the best we can with what we have, but it's not 100% preventing their seizures. There's not a lot of risk factors that we can identify for epilepsy. We know that children younger than 2 are more common to develop it, and in the older adults that are past the age of 65 might develop epilepsy. And something else to keep in mind when you wondered, if there's only 2 million people that have epilepsy, why do I need to learn these drugs? I might never come in contact with one. Here's the other thing. About 10% of Americans will experience a seizure sometime during their lifetime. And that's outside of having epilepsy. Those are people who might have had a provoked seizure that was unexpected, and then it's not recurrent. So you do need to know these drugs and the importance of the nursing aspect of taking care of patients who are being prescribed these drugs and medications. That is the end of the chapter from Giddens on intracranial regulation as it relates to seizures, epilepsy, and the medications and drugs that we'll be using here. So I hope this was somewhat helpful. Please, I hope you saw that you will want to revisit this chapter and this concept again and again as you learn glucose regulation and perfusion and pathologic things like Alzheimer's, dementia, brain tumors, and so on, because there's really good information here about how intracranial regulation is affected and impacted by those disorders. That's the end, and I hope you have a great day, and I wish you happy studying.